Hello, everyone. Welcome to another episode of What's New in Nerve. I'm your host, Telich, and today we're joined by Dr. Shai Rozen to discuss his latest publication. Dr. Rozen is a plastic and peripheral nerve surgeon based in Dallas, Texas, where he serves as a professor and vice chair of the Department of Plastic and Reconstructive Surgery at UT Southwestern. Today we'll be discussing his recent paper, Selective Myectomies Alone versus Selective Myectomies Combined with Neurectomies in Postparatic Synkinesis, published in PRS. This study compared two surgical approaches, myectomies of the DAO muscle versus myectomies combined with selective neurectomies of facial nerve branches. The results showed that while both techniques improved outcomes, the combined approach provided better closed myoscursion and reduced the need for botulinum toxin of the platysmal muscle. Now let's hear directly from Dr. Rozen about the study, its implications, and how it's changing the way we approach synkinesis management. Well, thank you, Dr. Rozen, for joining us today for this new section in Synapse. Just wanted to, first of all, congratulate you on your recent paper on PRS. It's very interesting. I know a big part of your practice is dedicated to patients seeking facial reanimation for facial paralysis, but this group of patients with synkinesis can be very challenging. We've seen them as surgeons, physical therapy wise, products treatments. They have high expectations, but sometimes we can't deliver what they're seeking. So the first question I would like to ask you is, how did you come up with the idea of writing this paper? What inspired you and your team to try to compare myectomies against selective neurectomy plus the myectomies, and why take this approach and compare them?
Well, I think it all starts from the patients. The challenges that they bring us. So we don't always have solutions, and every patient I see, I tell them ahead of time, like, I can never get anybody perfect. So that's a starting point. And then it becomes more of a teamwork approach. I think they understand that. And once they understand that, you have a lot more flexibility working with them and say, hey, there's certain things that we figure out, other things that we haven't. And this is something that we would work together. And one of the things is I always keep them in my practice in whatever way or form. Even if I've operated on somebody, I don't want just the next person to come in. I want to keep in touch with them for years, because it's relevant for this article. Because then things that we may have done wrong or wanted to improve, we get that feedback over the years from patients that we see after several years. More so if we come with something new, or if you come with something new and I look at it and I steal it from you and I like this a lot. I like what Jose is doing, and I'm going to apply that for my patients. They're still within my practice and I can do that. So this is a lot of that background for this article, that what we've gone about it in a way of learning a bit from our mistakes. So a lot of these patients, we did selective neurectomies and myectomies, and we were getting reasonable results. There were some patients that myectomies alone of the DAO was sufficient and it got us good results. But there's a lot of patients that it didn't. It made improvements, but it didn't get to what we really wanted. And then we added selective neurectomies. In addition to that, I used to add very aggressive platysmal myectomies. And then the hypothesis was that these patients we thought that they're similar to, in certain ways, we thought they're similar to flaccid facial palsy patients. We thought that their lower lip was paralyzed, that the DLI was paralyzed, and that they didn't have any activity. But what we saw when we did very aggressive myectomies in the neck area, suddenly some of these patients actually were a bit worse. And then you have to review your results. And we looked at them and said, well, if something's paralyzed, how can I even paralyze it more? So maybe it's not as paralyzed that we're thinking. And maybe there is something there else that's going on, but we're not paralyzed. So then I started looking at that and I said, well, what is it that we did? And our platysmal myectomy is very aggressive. And I think we probably may have injured some of the nerves going to the DLI. And then we kind of looked at that. And, during synkinesis surgery, you can stimulate a lot of things. So you learn a tremendous amount, way more than you learn with other surgeries, because here you're actually having the entire facial nerve. And you learn different patterns along the way. And it's really interesting to see that. So then I saw I was stimulating down the neck and wow, the DLI is working really well. actually stimulated in the DLI, so it's not paralyzed. And then we saw when we stimulated the mentalis how strong it was pushing up. And then we started figuring out, 1+1. It's like, we need to really protect this nerve going to the DLI. But maybe this mentalis is overcoming. Let's start weakening it. We started weakening it with the endarterectomies. And then we started seeing, like, in addition to the good upward motion, we saw the lower lip going down. And that really brought really nice results on these patients because their smile was not that smile up at the upper lip going down like we see with the flaccid palsy patients. We then figured out, wow, now their lip is going down. So it's almost like there's a muscle and a nerve that are working there, but they are masked by another muscle that is way overcompensating and way stronger than that. And we need to rebalance that. So I think that's what we wanted to share with the readers because we were enthusiastic about what we found. We saw a huge difference that it made for our patients. And, if you're lucky enough to learn one new thing in a week or one new thing in 2 weeks, it's fantastic, whatever it is, and this is for us like, hey, this is nice. This is really helpful. So, and people can apply it all over the world with this. And I assure you that it's going to help patients.
Amazing. Yeah. I mean, it's they're difficult patients to treat because expectations, they tend to arrive. I mean, especially here in Mexico, they tend to arrive late with us in consultation, and they're a bit desperate because physical therapy hasn't been working. They do Botox every 3-4 months, but they only get paralyzed and they don't recover movement. So it's amazing what you can achieve when surgery is applied in a proper way, right?
And I think, Jose, that one of the keys is waiting on these patients. So I've seen too many people attack these patients too early, maybe do surgery too early on them. And there has to be a waiting time first to see where they maximize. And yes, many of them are told they'll improve. On the one hand, they always consider improvement compared to how they started because they started with flaccid. So it's always good to remind them, hey, remember where you started?
Yeah.
You're a lot better now, but you have this other problem, so we're approaching it in a different manner. And I think once they get that conversation, they're like, yeah, okay, we understand. So we understand you're approaching it in a very different way right now. And we're going to be part of that journey. Yeah, so I agree with you. It's complex. Most of them come late. I have patients coming 20 years later, 25 years later, because they've been told that nothing can be done. And you have patients that just had a Bell's palsy and are paralyzed completely. You tell them, look, we're going to go through this together. And you're going to see me in 3 months. You're going to see me in 6 months, in 9 months. Once you start seeing that synkinesis, you're not competing with time anymore.
Okay.
You're actually going to deal with a completely different approach to these patients. So you're not competing with that time.
Exactly.
You're not going to get atrophy.
Great. Exactly. I think my second question would be related to the follow-up of patients and the whole evaluation. What is the thought process, or how did you define which patients only got the DAO myectomy and which patients got the myectomies plus the selective neurectomy?
Well, let me first of all thank Daniela Bay on this because I was in a meeting in 2017 and I saw what he was doing with the DAO myectomies. I couldn't believe it because until that time I was doing free flaps on most of these patients, gracilis. And then he says, "Oh yeah, 30-minute surgery and it's great." Patients, I'm like, "Whoa, really?" And he says, "Yeah, really. Let me explain to you." And then I started with that approach. And then in many patients it worked, but also many patients it wasn't a complete picture. It didn't give the complete solution. So I would say you can do DAO myectomies alone when really the majority of the problem is a hypertense depressed anguli oris going down the corner of the mouth. You can do a lidocaine block on them, and they improve, and they have fairly reasonable DLI activity, and their synkinesis is not that severe in the mid-face and those regions. And the neck is not pulling that hard. So it's a matter of really having something localized without too much severe synkinesis around the area. And I think those are the patients that you can do just by a DAO myectomy. I would always preface that with a patient to say, hey, we can go through this approach. And if you're happy, great. But if you're not, remember, we do have a plan B here, and we could do selective neurectomies.
Yeah.
Today, the majority of the patients, I would say 80 to 85%, I do them both together at the same time.
Okay.
But if we want to be selective in some, or if you're starting out to explore that area, then yeah, try to find those just with the DAO, do that, make them happy, and then kind of rolls along from there.
Okay, great. Thank you very much. Think the other question would be, once you're saying you have to do pre-op evaluation, the lidocaine block, and the post-op evaluation might be challenging. Like you said, it depends on, well, you have to see patient quality of life, patient satisfaction. But what objective measurements would you take into account for these patients? In your paper, I see you measured commissural excursion, resting smile. You used several softwares to evaluate patients. You also saw a decrease in Botox requirements for patients with neurectomies. But what do you use in a day-to-day basis in clinic?
So, look, in clinic, one of the things that I'm extraordinarily lucky to have is a group of professional photographers with us in clinic that they are incredible, and they have rooms, photographic and videographic rooms, and that's how we have such huge databases of photos and videos of like very frequently with patients. So it doesn't take from my time. It enables me later on to evaluate these other things when I'm going into research and studies, which is just phenomenal to have. On a daily basis, it's more about the communication, the regular day-to-day communication with physician and patient. Ask them how they are, just, getting into the small talk and then kind of seeing, hey, what they're so concerned about. For our audience to kind of give something more than that, I would say you can see results pretty quickly in many of these patients. Oftentimes, as they wake up in the operating room, you'll see differences. It's amazing, actually. Some of them will then get swelling, and I start massaging in about 2 weeks, 3 weeks in that area because I don't want it to scar, and some do scar and they retract a bit. And even in some of them, I actually give Botox because Botox does work with scars. Yeah. Amazing. And I've done it with keloids, Botox, and some of the results, I'm amazed myself. Like, wow, that's really interesting. So I actually give them in that area 3-4 weeks later in some patients just to maybe soften it up or decrease the chances. And I think massaging and that really improves the longevity. And at the beginning, I neglected that. I didn't know enough. And I did have some patients kind of rescar and reoperated because of release of scar and maybe some muscle fibers. Surgically, if you're doing the DIO resection, make sure you've got all the fibers.
Yeah.
Because if you're missing a few, you can really hurt the result.
Yeah.
So that's a combination of intraoperatively paying attention to everything, postoperatively massaging 2-3 weeks, maybe plus minus Botox into that area, mainly for scarring and for not kind of reconstricting in that area. That helps a lot.
Great, thank you. Well, you already told us a bit about what changes the surgery and your results had in your practice, but overall, specifically, would you say you have changed the way you do surgery in these patients, how you approach them?
Oh yeah.
Or is it still like a 50-50, or what are your thoughts about into the future with your practice?
I always want to evolve. So I think, again, we have such luck that we have such good recordings. So every time I'm preparing a talk, I go through multiple videos and photos, and then I'm like, oh my God, I thought that I had something good here, and it's not that good. And it's like, why is it not that good? So then I completely forget the talk, and I start thinking of, hey, we need to pay attention to what's going on here. So I think all this constant, activity, but, when you give a talk, you actually learn a ton. It seems like you're like the teacher, but you actually learn a ton in the preparation all the time. I always look for my patients, and the great thing about once you have good relationships with the patients, they really start working together with you on solving the problems. I have some that are persistent, despite the things, and they're like all game, like, hey, let's do this Botox here and here. I've never done Botox in this region, that region. Let's see how it helps. Hey, maybe we should be more aggressive next time. They're like willing. So yes, it's a constant evolution. You want to completely improve. It's like driving. You get your driver's license. First week you're careful. Next 3 months you're crazy and all the accidents happen, and then and then later on you mature a bit and you're good. It's the same type with these things. It's like there's a period you're like this, and then you're like this, and then you're like, whoa, okay, let's settle down a bit. Let's see. You got to learn. So we're in that stages of always finessing things and looking at things. And we just wrote a big article, and I kind of pulled it out, and it really reviews all the mechanisms that we know of on synkinesis. And it just tells you that, first of all, it tells you that when you have so many mechanisms, you actually don't really know maybe what it is, or it could be multifactorial with multi-stages, meaning you could have one injury that subsequently causes changes at the nucleus, causes changes at the cortical level. The question is, are we going to see reversibility by correction of some of the things that we do? We don't know that yet. So I think if we understand and look at this, then I use these types of explanations to my patients in terms of telling them, here's what we can maybe do, but here are the things that I cannot do. I cannot control your nucleus or the facial nerve. We can maybe control your cortex by a lot of exercises and by things that we're doing. And that's one of the things that I think is most important, that I tell them, hey, I'm going to bring you to a certain level, but beyond that, one of the most important things is you trust yourself and you get rid of bad habits. Okay. And you start smiling, even though it's not going to be perfect, just smile spontaneously. The brain is so unique from a perspective that when they smile spontaneously, they get better results than when they smile voluntarily.
Okay.
So when you ask them to smile, their smile is okay, but when you make them laugh, they do very well. And that's very different than our other group of flaccid facial palsy patients who are reanimated, et cetera, et cetera. These people, individuals have spontaneity. They just have changed so many things habitually because of this, not smiling, masking their face, doing that. I tell them, I'm going to try to bring you to a situation that you can do things better, but you have to relax. You have to accept what you have and just smile, and you'll actually produce a better smile that nature actually provided you. And that's really amazing to see that. And I learned that from patients, because I had a patient that was happy 80%, but not completely. She sent me pictures from the sky diving. She was with a mentor. She was like, on this thing, and she had the teacher behind her, and videos were being taken of her in pictures. She didn't know, but then they gave it to her, and she's looking at it. And it's a full smile. And she says, "Whoa, this is incredible. It's the first time." I said, "Yeah, because you were spontaneously smiling." So that's one of the big differences with this group of patients. They actually know how to do it. They need to let go. Otherwise, they confuse themselves.
Yeah, that's very important. I mean, like you said, surgery and injections and treatments only can get you so far, but patient communication and patients doing their part is also
it's key.
Very, very important part of.
They have to be process. Stakeholders and be part of the process, and I tell all of them at the very beginning, we're working as a team, and that's when we get the best results.
Amazing. Sure. And well, thank you. I think my final question is not so much about the article, but more so dedicated to people like me who are just starting operating people with synkinesis. What caveats would you give us, not just on the technical point of view, like learn lots of anatomy and read your books, but sort of more of a day-to-day recommendations in treating this group of patients, or precautions during surgery as well?
Well, I think the number one thing, you have to be curious. You have to be curious about a problem and how to think of solving it. And I think when you start with that approach, then you start reading, you start looking at different things, you start listening in different ways. And then you also have to really be open with your patients. Tell them, hey, this is an area that it's an evolution. I'm telling you this up front. I don't have all the answers to it. You just have to believe my intent that I'm here to try to help you. I think once you get there, then a lot of that fear of, hey, might you do a mistake or something wrong goes away a bit, because now you're really teaming up and you're working together. Then you have to have a very open discussion what you can and what you can't do. One of the things that I can never achieve control on is pathological contracture oftentimes. Like, I can't really guarantee that you're going to get less oral ocular or ocular oral synkinesia. Many patients report decrease, but I tell them, look, that is not the primary objective. The primary objective is to get you more balanced at rest, get you better in the smile, get you better at all these aspects. These are things that I can control better. Other things, I know you feel tense here. I can't decrease that. I can give you maybe some Botox, but I'm not going to paralyze you to be feel less tense, unless you're in such a high degree of severity. And I have a few patients that's the philosophy of David Schwann, says let's paralyze them completely and rebuild them. I don't oppose that philosophy, but you have to be very selective in the patients that you do that. And I think you have to be comfortable in these surgeries and any surgeries before you do that. And my approach to those patients, I paralyze them with 70, 80 units of Botox and tell them, you remember how you were? I'm going to remind you again. And I paralyze them for 3 months. I said, are you okay with this? Because that's what will happen if I do very aggressive selective neurectomy and myectomy. Not a lot of patients like that, but I have patients like that. The other thing I'd say is from a technical perspective, you must have a very good stimulator. You can't do those one-timer stimulators. You have to be able to produce tetany and not tire those nerves. So you have to be able to do it 20 times and see tetany, like see that muscle like contract and keep it there and let it go. Keep it there, full control. And that's only with good stimulators. They're a bit more expensive, but you cannot do the surgery without those stimulators, because you have to map every branch of the facial nerve. And that's what I do. I put loops around it, map it, and then I read it out. We all look at it, everything that's doing. And the other thing is similar in a way to donor nerves. You never take away a nerve that you find that it's necessary. I'd rather have the patient with a bit of synkinesis and not paralyzed than the other way around. But there's so much overlap that once you get experience with this, you'll understand where to take something out and where to leave it. And if there is something that proximally does something that you don't want, but also does something that you want, and you can't find another nerve that does what you want, then you can further dissect it distally until you see a separation.
Okay.
It takes a bit of technique, but you do that. You stimulate, and then you see, oh, this is the branch that I want, this is not, and then you cut it more distally. So it's games of that sort, but I promise you'll have a very good understanding of the facial nerve once you get into it. But you have to have a good stimulator. Otherwise, you can't do it. You're not going to get this feedback. And without that feedback, I would suggest not doing the surgery, because then you're kind of, there's too much unknown in what you're doing.
Right. Well, I think that's all the questions I have for now about the article. I'm sure we have lots of questions about synkinesis and selective neurectomies. Thank you so much, Dr. Rozen. On behalf of this whole Synapse team and Nerve Nerds, it was a pleasure meeting you. And I hope we meet in person later in Hawaii next year.
Absolutely. I'll see you in Hawaii. Okay.
You too. It was a pleasure. Thanks for watching and making it this far. Don't forget to like and subscribe our video and follow us on social media on Nerve Nerds.